thank you for the introduction. So I changed the title a little bit. So we're talking about hypertrophic ventricles rather than HCM, because HCM is a diagnosis of, is a genetic diagnosis. Someone who has hypertrophic cardiomyopathy has a gene defect, basically, right? And this is hereditary. But what we're talking about here is having someone with hypertrophic ventricle. You see the patient, and you see the LV is thickened, and you're looking for very important etiologies that was mentioned lastly in the last presentation. So when someone presents with a thick ventricle, you're looking for many different reasons. One of them is hypertrophic cardiomyopathy. Do I have the mouse? Maybe this one. You see my mouse? No. So hypertrophic cardiomyopathy is one of the non-infiltrative. Yes, thank you. So it's one of the non-infiltrative cardiomyopathies, and it's probably what comes to mind first, because we were trained that this is a very high risk situation. These patients have risk of sudden cardiac death. You need to look at if they have hypertrophic cardiomyopathy, you need to give them specific therapies. You need to see if there is obstruction and how to treat that. But always comes to mind the adaptive response of an athlete. So this is something that you look at. Is this patient an athlete? Do they have normal or actually dilated ventricle with thickened walls? And is this just something adaptive that will recover? And then there are other causes which we're very familiar with, conditions that causes volume overload from valvular dysfunction, or pressure overload as well from valvular dysfunction, and hypertension. And you understand that these conditions can be reversed. And then cancer is one of the rare causes of hypertrophied ventricle. We rarely see it, but it can having infiltrations in the myocardium is one of the reasons. But then left the last part, which has been more and more mentioned in the literatures for the past years, because now we have a therapy for that. So we're talking about infiltrative cardiomyopathies that causes ventricular thickening. And the one on the top of mind is amyloidosis, specifically because we're all adult cardiologists, and it's a disease of the adult. Other kinds of infiltrative cardiomyopathies are seen in younger age. You can see Fabry disease in young adults, but if you're talking about elderly population, you're mainly thinking about cardiac amyloidosis. So this is. You remember the classic teaching, hypertrophic cardiomyopathy, infiltrative cardiomyopathy. Now, these kind of diseases have both presentation. So amyloidosis can be hypertrophy, and it has restrictive physiology. The same applies for Fabry disease and glycogen storage disease. They present with hypertrophied ventricle and have restrictive physiology. So it's important to keep in mind these different types. So cardiac amyloidosis, as we said, it's an infiltrative process. It's caused by extracellular deposition of misfolded protein that is forms insoluble amyloid fibrils. They cause structural damage to the heart and impair its function, but it also deposits in other organs. So that's why you usually have multi-organ involvement. It frequently presents as heart failure, so that's why it should be on top of your mind whenever you have someone presenting with heart failure and hypertrophied ventricle. Of course, the pathogenesis and prevalence depends on which type of amyloidosis, but it's usually misdiagnosed because most of the time it's not really on top of your mind, and there is lots of uncertainty about, or there used to be lots of uncertainty about how to diagnose this disease. Lots of people thought that you needed myocardial biopsy to diagnose that, which is not true anymore. So what are the clinical red flags? We always talk about red flags. So there are clinical red flags, there are imaging red flag, ECG red flag, and biomarker red flags. So with clinical red flags, you're looking for other organ dysfunction as well as heart failure. So mainly looking for peripheral and autonomic nervous system dysfunction, kidney and gastrointestinal disease, autonomic dysfunction, and very important to look for bilateral carpal tunnel syndrome. Usually, if carpal tunnel syndrome happens because of misuse, it's usually in the most dominant hand. But if you have bilateral carpal tunnel syndrome, then you're thinking of an infiltrative process that occurred in both hands. Family history of heart failure is very important because there is a hereditary type of amyloidosis that runs in the family, and very important to remember, and responsiveness to heart failure therapy. So if you have someone who you started them on heart failure therapy and now they cannot tolerate it anymore, they cannot tolerate ACE inhibitor or beta blocker, you need to think about infiltration as a cause of this process. So these are all the extracardiac manifestations. Probably you remember some of them from medical school. This was something that we learned for exams all the time. So there's the soft tissue infiltration. So you find microglossia and the famous picture of a big tongue protruding from the mouth, having a rash, usually periorbital rash, bilateral carpal tunnel syndrome, muscular dystrophy, lymphadenopathy, and arthropathy. There's also liver and spleen abnormalities, so hepatosplinomegaly, elevated liver enzymes, having GI symptoms. This is very important, and we tend to not ask about this as cardiologists, but having constipation alternating with diarrhea, early satiety, and weight loss. And early satiety is something that you see in heart failure patients as well. So it's very important to keep in mind that this might not be just, cachexia of heart failure. This could be also infiltration from amyloid into the GI system. Of course, ophthalmological, they can have glaucoma, they can have intravitreal deposition, they can have pulmonary involvement with pleural effusions and diffuse alveolar infiltrate. And of course, they can have nervous system involvement as peripheral neuropathy and autonomic dysfunction. So there are different types of cardiac amyloidosis. There is the AL type, and there is the ATTR type. So AL is associated with hematological problems. And usually when we get to the diagnosis of AL amyloidosis, we hand over the case to the hematologist to carry on the investigation and get to the diagnosis. Whereas ATTR cardiomyopathy is the disease that is mainly concerned to cardiologists. It's a disease of the elderly. It could be hereditary, and it does present with heart failure with preserved ejection fraction. Now, there are other types of amyloid that are less common, but 95% of amyloid could be either AL or ATTR. So light chain amyloid or AL amyloid, as we mentioned, it's a hematological emergency. It accounts approximately 70% of patients with amyloidosis, and it has very poor survival. So it's very important to diagnose these patients accurately and quickly so they can get the proper treatment earlier. And it's funny how whenever we diagnose AL amyloid and we talk to hematology, they say, well, it's too late now because it reached the heart. Because once there is cardiac involvement, their prognosis is less than 6 months. But if you catch them without cardiac involvement, they can live more than 4 years. Of course, this is an average prognosis. It doesn't mean that it's too late. You still need to refer them to hematology. They still need to undergo the treatment to improve their survival. So if they're treated, they can live up to 5 years. And if they go for stem cell transplantation, they can live for more than 10 years. And the main way of diagnosing these patients is by doing the kappa-lambda light chain immunoassays and immunofixation with serum and urine protein electrophoresis. So usually patients with AML amyloidosis are younger than patients with ATTR amyloidosis. They're in their 50s. The distribution between men and women is the same. They have some cardiac involvement, so they can have restrictive cardiomyopathy, low QRS voltage, and conduction disorder. But they also have all other extra cardiac manifestations that we mentioned before, like diarrhea and constipation, polyneuropathy, macroglossia, and bleeding diastasis, and preorbital ecchymosis. Now, for ATTR cardiomyopathy, so there's two types. There's a wild type and there is a hereditary type. The wild type usually occurs at the age above 60, and 80% of the diagnosed patients are male, so it's underdiagnosed in women. usually presenting as heart failure and some conduction abnormalities and atrial fibrillation. And they have extracardiac manifestations as well. So bilateral carpal tunnel syndrome, spinal stenosis, which is very common in the population that we have here in the UAE, and presence of atraumatic biceps tendon rupture. Now, the hereditary type, usually patients will have family history of cardiomyopathy. They do present with conduction disorders and heart failure and infrequently atrial fibrillation. And they do present with more polyneuropathy. So usually these patients have lots of neurological abnormalities, and the heart is part of that problem. So these are all the red flags that we can see in these patients. Usually with the wild type, you see the spinal stenosis, the atraumatic biceps tendon rupture, and the bilateral carpal tunnel syndrome. Well, you have most of the other red flags in the hereditary types of ATTR with the polyneuropathy and the GI system involvement and liver and kidney involvement. So biomarkers are easy. They're done almost for everybody. Anyone who comes to the emergency with a toe pain will get a BNP and troponin. And you would see that they are elevated in patients, chronically elevated in patients with amyloidosis. So NT-proBNP is universally elevated. Troponin I or troponin T are also universally elevated. So if you have a patient that you follow and you see that they have chronically elevated unexplained troponemia, this is one red flag that you need to remember. And it helps stratify patients with risk of hospitalization and morbidity. ECG red flags. So the classic teaching was with ECG, you would have low voltages with cardiac amyloidosis, but that's not the case all the time. Actually, an ATTR cardiomyopathy, low voltage will be around 20% of patients. In AL amyloidosis, it's more common. But what's important is to remember that there will be a discordance between the ECG and the echo. So when you see the echo, you'll see a thick ventricle, but you look at the ECG and it looks normal. So that discordance is a red flag. Also presence of a pseudo-infarct pattern, which is a Q wave in the anterior lead that points towards cardiac amyloidosis. And of course, the presence of conduction disorders and AV blocks and atrial fibrillation. Now with echo, there are many features in echo that points toward cardiac amyloidosis, and it's probably the place where you start suspecting the patient from. Of course, you're going to have thick ventricles. It could be right and left ventricle. Both of them are involved. The valves are thickened. The interatrial septum is thickened. And there could be pericardial effusion. You don't see it in this view. But here you see all the left ventricle is thickened. The right ventricle is thickened. Interatrial septum is thickened. And you have biatrial enlargement. You will also see what we call the spickle pattern in the myocardium, where it looks grainy a little bit and too bright. Here you can see the pericardial effusion. And if you perform a global strain, you will see that it is depressed all over, but preserved at the apex, which creates a gradient of 2 to 1 between the apex and the base. And that is suspicious of cardiac amyloidosis. So again, the same findings that you would see with thickened ventricle and biatrial enlargement. Of course, you will have diastolic dysfunction, so it's very important to assess diastolic function in these patients. And yeah, kind of missed this one. And they're more likely to get clots. So you see here, this is actually a left atrial appendage clot that you saw in the subcostal view. So patients with amyloidosis will get clots even if they're in sinus rhythm. Actually, this patient is in sinus rhythm. I think you can see the peak. And this is more of the spickle pattern and diastolic dysfunction with decreased S prime velocity as well. These are all red flags of cardiac amyloidosis. And this is the strain pattern that we mentioned with apical sparing. Now with CMR, you can, as you heard from the previous speaker, you need to do CMR in patients with hypertrophied ventricle because it can give you clues to the diagnosis. Usually with cardiac amyloidosis, you will see an increased T1 signal and a diffuse late gadolinium enhancement of the LV. And an increase of extracellular volume. And this actually can be measured, and it will give an idea about how much amyloid there is in the myocardium. Lost my slide. Here we go. So I'm just going to go through the last few slides because I think we're running out of time. So nuclear scan has made all the changes in the diagnosis of cardiomyopathy because of amyloid cardiomyopathy. Because in ATTR cardiomyopathy, just by doing a nuclear scan, you'll be able to see all the uptake in the myocardium that's usually taken by the bone. So something like this is clearly abnormal, and that points to ATTR cardiomyopathy. You don't see that for AL amyloidosis, and you don't see that, of course, for a normal patient. So why red flags? Why we're talking about red flags? Because it's important to look for these red flags in patients with LV hypertrophy. If you have one or more red flags, then you need to screen for cardiac amyloidosis in order to diagnose the patient and start them on therapy. So this is from the ESC consensus statement. So if you have LV thickness more than 12 millimeter, which is not that thick, but just to pick up more cases, they chose more than 12 millimeter, and then one or more red flags, you need to look for amyloid cardiomyopathy. The diagnostic algorithm for treatment, for investigation, is fairly simple. Do a PYP scan and do the hematological workup. If the hematological workup is positive, send them to the hematologist. If the PYP scan is positive, look for ATTR cardiomyopathy. If you're in between, then you have to look for an expert to help you. I think that's the easiest way to look at this. This is the ASC gram. It's a little bit more complex if you like to think about it, but I think the best step is just to do these two things. And if you got that that part, then you can get the help for your patient. So with that, I conclude my talk. Thank you very much.